I want to thank the organizers for giving me the opportunity, and I think even though initially it seemed to be not well accepted that there is a lymphoproliferative phenotype in ADA2, I think now we've had good examples of that already today. So I come from the Institute for Molecular Medicine, and why I stumble into these ADA2 patients is that we are running the clinical diagnostics sequencing service for most of the Finnish immune deficiency or autoimmunity patients, and that's how we identify the patients. So in Finland we currently have 9 patients with ADA2 deficiency, and all of them have the arginine 169 glutane mutation, either as a homozygote or as a compound heterozygote with another mutation. Only one family has the classical stroke PAN phenotype. All the rest are more of a cytopenia and lymphoproliferation type. Most of the families are non-consanguineous, and why we have so many homozygotes for the particular mutations is because of the genetic background of Finns. Just a short reminder that in Finland we have overall fewer mutations fewer variations. So basically private mutations are much less uncommon in Finland as they are in other European populations. But what we have is an enrichment of certain mutations that are deleterious and can actually be of very high frequency. That's the reason why we have the homozygotes there. We have a certain group of diseases because of that. They are called Finnish disease inheritance, recessive, very deleterious diseases, and in most cases there is one major mutation causing the disease in Finland. So doing genetics in Finland is easier than elsewhere. About our ADA2 deficient patients and their phenotype, as I said, only one family had the PAN phenotype, although there is a skin vasculitis in 2 other patients as well. Lymphoproliferation is seen in all the other patients, so 5 of the 9. And all of them have some type of cytopenia, neutropenia, lymphopenia, thrombocytopenia, not that much red cell aplasia. Autoimmunity is a general feature, and almost all of them are immune deficient. CVI or hypogamma is seen, actually there's a mistake there, in 2 patients, and as I said about the vasculitis. So if we look into the patients with lymphoproliferation a bit in more detail, so 2 of the patients, the adult ones, have LGL leukemia, and that's atypical LGL, so they don't have one major clone that would be invading the bone marrow and the liver, but there are several clones, and they are not driven by a particular mutation, the clones. There is in addition to them, in 2 younger patients, there is T-cell, the one 7-year-old and 8-year-old, T-cell infiltration in a BMM liver. And the one that is 7-year-old has been transplanted and is doing well. There are no other symptoms anymore. The 8 years old was initially shown neutropenia and skin manifestations. She has been treated with neutrophil growth factor, not responding very well. She's also been treated with TNF-alpha inhibitor. She's not responding to that, so it seems to be an intrinsic problem of hers. And now she's developed a severe T-cell infiltration in the bone marrow, and they are considering transplantation for her. Her aunt, who is a 19-year-old, was initially described as CVID and has been treated as a CVID patient. She has now developed also 3-cell lineage cytopenia and is not responding to treatment. But we have not done a bone marrow study yet, so we don't know whether she would also have the T-cell infiltration. All of them had splenomegaly and lymphadenopathy. Since in a few years ago with Satu Mustjoki group, we described STAT3 as a driver mutation for TLGL leukemia. So we wanted to see if a STAT mutation would explain also the LGL in our patients. And what we saw was that, yes, indeed, they have very minor STAT3 somatic mutations. They are not confined to the enlarged T-cell clones. And you can see them both in CD8 and CD4 cells. So they are definitely not driving the LGL in these patients. As Ivona mentioned, in quite a few other immune deficiencies, there's also lymphoproliferation and autoimmunity. And we did a pilot study to look into if somatic mutations would be actually explaining this more widely. So we analyzed 15 patients with CVID and some type of lymphoproliferation and looked at somatic mutations. And actually in most of them we do find minor clones, but almost as frequently we find them in controls that are of same age. So obviously that would not be the major cause for it. Also, all our patients have been exome sequenced, and there is no other explanation for the lymphoproliferation, and we've also tried to match or compare them with each other if there would be something novel explaining it, but there isn't. So it's really part of the ADA2 phenotype. And I just stop there to give us some time. Thank you.